Good afternoon. Hello. It is straight up 4 o'clock p.m. in the Mountain Time, which means 6 o'clock on the East Coast and 3 p.m. on the West Coast. And there is only one place you should be right now, and that is Fertility with Fink and Friends. My name is Dr. Randy Fink, live from CNY Fertility in Colorado Springs. I am Fink. You are friends, and it's great to see everybody on this Tuesday afternoon, like we do every Tuesday. So good to see all my friends joining in. Let's see, Rock 45,000. Peps in her steps. I like that name. We've got a couple of different Instagram feeds. We've got YouTube and LinkedIn and Facebook right here in the middle, and another Instagram feed over here. And who was the first? BJ Pumping. Hi, Alexis. Lexi Lorente from the beautiful and wonderful Miami Center of Excellence. Great to see you this afternoon. And of course, a very special shout out to my own lovely mother and father who are with me in Mobile, Alabama, the great state of Mobile, Alabama. Hi, Selenio 2011. Vix Lojo, Shanty Dib, good to see you. Haven't seen you in a little while. Wooboo 21, and who else here? My friend Carly is here, who I understand is going to be having a transfer in the next couple of days. Hello to Brock and my dear friend Angela. Thanks for being here, and to Leah. And oh yeah, Carly just said transfers tomorrow. See, I knew that, and you didn't even have to tell me. Hi from Wisconsin or hello to Wisconsin from Kizzy Powell. Gosh, nobody's joined us yet over there on the Facebook side to say hello, but sure is good to have everybody. It's been another fabulous week here at CNY Fertility in Colorado Springs. We got a little snow over the weekend, I believe, but of course, as per protocol, it melted off pretty quickly. I have to say a couple of shout outs if I can also here. Again, special thanks to everybody, all my old friends who are joining. But I got some very special little gifts that I want to say thank you for. This is the first one. This is official Fink and Friends socks that come from my friend Erin in embryology, and I think they are wonderful. She pulled a bunch of pictures. They are actually all different off of the Instagram feed for Fink and Friends socks. This comes from Zenny in Miami. I call the shots. Yes, I do. And a couple of other pairs here, and boy, very special stuff. Thank you for that. Got a real special little sign behind me here that was handmade for me by my friend Jody from embryology. Jody, you may recall, visited with us here on Fink and Friends several weeks ago. I was so touched to know that she actually pays attention to what I say. And you may know that when I close the program here, I have a particular saying that I like to say every week. And she made that into a sign, which is now behind me on the wall there. And I think on the Instagram feed, it's probably backwards because these iPads are looking the other way. But kindness, love, and hope, and that this is not it's not your book, that this is all just a chapter in your life that we're here to help you rewrite. So gosh, Jody, what a very special thing. And I'm going to make sure I leave that one in the frame over there so everybody can see it, even if it is backwards. So hi to Melissa Salustino. I'm an IVFing unicorn. I really like that. Looking forward to consult in July. Hey to AK Bond from North Dakota. And let's see. Oh gosh, all kinds of folks have signed up here over on the CNY side. That's so Libra. I have to tell you, Libras rule. Libras rule. Scorpios drool. Right. I'm a Libra. October 4th. Let's see who else we have here. Kathy Hull. I love my it looks like. Let's see. Wanda Wanda, which I love the socks. Thank you for that. Hi to Sunbow Dots. I saw a question up here. Kizzy Powell is looking forward to scheduling a transfer. Shanty Dib has no admission today, just to be in person. Hi from Texas to Kel Dobbs, and I swear I saw a hi from Wisconsin. That's Kizzy. Okay, Storm in Michelson. It's Tori. Oh, it's Tori Michelson. Sorry, it's reading in English is not my specialty. So I have a question. I have had bleeding in between my cycles since a failed transfer. What can cause this? Scared to transfer till it's fixed, and no wonder because we want everything to be just right. We want everything to be just perfect. So I presume what that means is that you had an embryo transfer and it didn't work out, and that's okay. I don't like to call those failed transfers. I say, it was an unsuccessful transfer, but nevertheless, we always learn something from every one of these events, whether it was medicated, how you're going to metabolize those hormones. If it was a natural cycle, how your ovary is going to respond to that. So really, I encourage you not to think of these things as or rather as failures, but rather as unsuccessful. If they didn't result in a pregnancy, they will result in a pregnancy. But every time we do something, we learn something, and that's really important. Okay. All right. So you had that transfer. It didn't work out. And I don't know when that was, Tori, relative to where we are now, but some bleeding in the mid-cycle. So oftentimes that bleeding comes from a couple of different things. The first thing I would always want to know is, when was the last time your uterine cavity was evaluated? Because polyps will bleed in the mid-cycle. And so we want to know if you have a polyp there, because it's taking up valuable real estate inside that uterine cavity that could otherwise be used for a pregnancy to implant. Additionally, sometimes think about it, it sits in there and it can function like a little baseball bat and like a windshield wiper, knock it right out of the park. So I want your uterine cavity to be evaluated. Sometimes it just comes from the cervix, and sometimes it comes from, and the cervix can be just because there's a little glandular tissue there that may get nicked from the catheter, and then it sort of forms a little scab that sometimes will sort of keep bleeding. And it also can be a little blip in the hormones that has to do with ovulation. The most important thing, Tori, is I'd want to make sure that the uterine cavity is normal, that's been evaluated. And if that's been evaluated, I'd want to take a look at the hormone levels and see what they're doing and make sure that everything looks kosher. So how about that? Let's say hi to Mandy over on the Facebook side. Hi, Dr. Fink. Can you please explain the differences in meds used for a medicated versus a modified natural frozen embryo transfer? What factors besides needing to ovulate on your own would make a modified maturation a good choice for a patient over the medicated? So it's a great question, and it's something that I spend a lot of time talking about every single day on the telephone with folks. I'm a big fan of the modified natural frozen embryo transfer. So what does all that mean? With a medicated FET, frozen embryo transfer cycle, this is what we have done in IVF for the last 40 years. So it's nothing new. It's the old way. There are volumes of literature on it that show us how it works and what it does. And the reason that we do it this way is because when we are giving you all the medications, and that's in a medicated cycle, we are controlling every variable in your cycle in order to find just the right moment in order to place that embryo in. Right? So that's in a medicated cycle. We give you 6 to 12 days of estrogen. That estrogen thickens up the uterine lining. And then you get 6.5 days of progesterone in the form of progesterone and oil, the injection. Then you get your transfer. So when we do this, we're giving you the estrogen, which suppresses your own hormonal function and replaces it with the hormone that we are giving you. So that again, we're controlling every aspect of that hormone. So we know exactly how much should be in your body, how you should be metabolizing it, and what your body is supposed to be doing with it. All right. That's a medicated cycle. Then you stay on that progesterone injection in particular. You stay on the estrogen as well. But the one that everybody knows about is the progesterone in oil because it is one of our least favorite modalities in this industry. You stay on that until you're about 10 weeks pregnant. Why is that? Progesterone is the important hormone that maintains your pregnancy, progestation, right? Progesterone. You stay on that because by about 9 weeks of pregnancy, your placenta takes over for making the progesterone. Up until that point, normally it would be your ovary. If you got pregnant naturally, it would be the ovary that makes that progesterone. But since we're giving you all that hormone, you have to stay on the progesterone shot. So that's a medicated cycle. In a natural cycle, we're letting your own body contribute some of its hormones to the equation. All right. So what does that mean? Well, usually what we would do in a modified natural, we're going to give you ovulation induction, usually with letrozole. So you'll take 5 days of letrozole, which is going to make sure that your ovary releases an egg. You're going to form that egg or that follicle, which we can see with ultrasound, and we watch that follicle grow. As that follicle grows, that's where your estrogen naturally comes from in your cycle. So let's say that you're not trying to get pregnant. You're just having another month goes by. Well, you get your period, your ovary starts to make that follicle starts to grow. That's where your estrogen naturally comes from. When that follicle reaches a mature size, we can trigger the ovulation, which tells the ovaries that we're ready for you to kind of start thinking about releasing that egg because, and that also is what starts the clock ticking on when you're going to have your embryo transfer. But when the ovary releases the egg, just like under any other circumstance that you're going to ovulate, that is where you make your own progesterone. And the fact that you're making your own progesterone is probably where what I call the magic sauce lies in this whole thing. And that's why a natural cycle or a modified natural cycle probably has a little bit better of a pregnancy rate, a little bit lower of a miscarriage rate, and certainly there is a lower risk for certain types of pregnancy complications that happen later on. So I'm a big fan, and I think you should be too. There are some circumstances where a natural cycle just really isn't going to work right, where you're not growing enough lining, or there can be a variety of different things. Now, purely a natural cycle is where you make that follicle yourself. Like if you have a regular period, that means you are probably ovulating every month in order to get that period. So in a natural cycle, you make that follicle, it grows, without us giving you the ovulation induction. But curiously, there is some evidence that shows us that using the modified natural, taking the medication to make sure that you're going to ovulate, has a favorable effect on the uterine lining. I would have thought it was opposite until I was actually shown a very nice piece of evidence, a big study that was done that looked at the modified natural and found that it actually in many cases works better than a natural. So that's what a modified natural is versus a medicated cycle. So we give you a trigger for the ovulation, your ovary releases the egg, you start making your own progesterone. We give you a little extra progesterone as a local effect in the form of a vaginal suppository, but you don't have to do the shot. So medicated versus modified natural. Right here, big fan of modified natural. I would encourage you all to think about doing modified natural. Now, if you're at CNY and you're purchasing the package the bundle of medications that already includes medications for a medicated cycle, because again, medicated cycle is the way that it's been done for decades, and so it's hard to shift those gears outright. And modified natural may not be the right choice for everybody. So certainly do ask the question. If you're under the care of the global team, it's worth asking about. If you have a consult with one of us, worth asking about. I feel strongly. Hey, thanks so much, Mandy, for that question there. Let's see what we got there. Hi to Jody O, a special hi, who gave me that thing right back behind me. And I hope that you heard me talk about it. Oh, look here. And Zenny is here. And I hope you heard me say thank you so much for these beautiful things. I appreciate that very much. Leah is going to be coming to Colorado just after New Year's. Can't wait to see you again. A special shout out also to the wonderful and talented Jody Hoffman from the global team who is with us here. Here's a question. Do you need a full 90 days on egg quality supplements before retrieval? I had a failed FET and am doing a retrieval hopefully soon. So here's the story about the supplements. And, there is kind of a big list of those things that come from the book. It starts with the egg. And I'm happy to send you that list if you'd like to instant message me. If you do so, I got to have your phone number and I got to have your email address so that I can send them to you in the proper format. So, it was always said, and it is true, that as we mature, right, it's harder and harder for us to be able to have a baby. Even in nature, it's easier to get pregnant when we're younger. And that's why, as we start to approach 40, it gets more and more difficult. The pregnancy rates go down. Why is that? Because the DNA that's in our eggs becomes less stable. And as a result of that instability, we start producing abnormal eggs, which make abnormal embryos, and abnormal embryos typically just don't implant. That's the problem. And so the same thing happens in nature. Many of our pregnancies end before we even realize that we're clinically pregnant. So in IVF terms, we're making eggs, we're retrieving eggs, and we're making embryos with those eggs. Some of those embryos are not going to be normal embryos. And certainly as we age, the probability of creating abnormal embryos goes up. Well, so the older wisdom was that, the DNA in those eggs is being damaged just based on aging alone. But now the thinking is that the damage to that DNA happens in a two-step process. There certainly is one step that is a result of just kind of being in those eggs for our lives as we get to that point, because we're born with all the eggs that we'll ever have. And so the DNA in those eggs, just like the rest of us, starts to age. And I'm like, here I am. Just like that happens, really at the level of the ovaries and the eggs as well. But now there's thought to be a second step in that process, that in the 2 to 3 months before that egg gets recruited for release, that there is another step, and that may be something that we call oxidative stress, oxidative type damage, which happens as a chemical reaction. It's the chemical reaction in our body that causes inflammation. And I could go into a good explanation of what oxidative stress is here, but you probably aren't all that interested. However, it's that second injury to the egg that causes, to the DNA rather, that causes that egg to be sort of permanently altered. And so what that suggests is that there is about a 90-day, probably a 60 to 90-day window that we have before that egg is recruited, that we have the ability potentially to stabilize or to repair some of the age-damaged DNA. And that's the rationale behind using these supplements. And that's what the book, It Starts With the Egg, is all about. It's the research, it's the evidence behind what it takes to repair those eggs. So, I certainly think that 60 days minimum is probably what you need there, Ms. Unicorn. But 90 days is probably ideal. Hey to Grace and to AK Bond, we're planning for round two of for a transfer. Do we recommend doing something different? Well, first of all, you did a medicated cycle. So I would certainly say it makes great sense to think about switching gears and doing a modified natural, and to make sure that you're on the supplements that are on the list as part of the embryo transfer protocol. That's a prenatal, that's CoQ10, that's vitamin D, it's vitamin E, and it's L-arginine. And I'm happy to send you that list if you like, but that's what we're looking for. Hey to Rusick Blue, and the lovely Mrs. Vince is here from Kentucky. Great to see you, and hope all is well. I hope you don't mind, but I'll share a little something here about Mrs. Vince, who had a big scare in her early pregnancy. She had what was called a subchorionic hemorrhage. And we've talked about this before, but if you weren't here for it, it's a very common thing to happen in the early part of pregnancy. And basically what happens is that as the uterus is slowly growing, the placenta, which sits along the uterine wall, the uterus grows and the placenta starts to move. And as it moves, it can shear off a little space underneath it that collects with blood, just like it's a little bruise that's under the placenta. I will tell you that that which is called a subchorionic hemorrhage is very, very common in the IVF world. When you create a bruise, so just like I got punched here in the leg, it turns all kinds of colors. You know, it turns black and blue, and then it gets all yellow, and then it's kind of orange, and eventually it goes away because that blood that's collected under my skin ends up getting reabsorbed into the system, right? If you've got kids, or when you have kids, you will realize that they are forever getting little bruises right here, because they're always, especially when they're toddlers, they're always running into things with their forehead. So I learned a wonderful little trick about that from our wonderful nanny, whose name is Patty, who lives in Miami. Patty comes from Colombia and was with us for 12 years. She is absolutely a member of the family. But there is a cream that you can get at the store. It's an herbal remedy that's called arnica. Arnica, arnica. There is also, I've seen them in brand names, Arnicare and so forth. Arnica cream will make a bruise disappear practically overnight. It's a wonderful thing to use. So if you get Botox in your face and you get a little bruise, put some arnica on it, but especially for the kids to make those bruises go away. Patty is, we are forever in your debt for so many things. Let's see. I totally lost my train of thought there. Oh, we were talking about the subchorionic hemorrhage. So you collect that little collection of blood. Some of it has no place to go but out the door, right? And the vagina, the cervix is very close, so out it goes. And that's when you experience vaginal bleeding, which is a terrifying thing to have happen in the first part of pregnancy. But 50% of normal pregnancies will have some cramping and bleeding in that first trimester. So it is a very scary thing, but in most cases that will resolve and the pregnancy continues. So once you look and you see a heartbeat, we know that 95% of those pregnancies will continue on. Once you're beyond 12 weeks, 99% of those pregnancies will continue on. So seeing a heartbeat's the best thing that we can hope for. When you have some bleeding, that's usually what we'll do. We'll take a look with the ultrasound. Once we see that heartbeat, we feel very reassured. Should you be on bed rest after that kind of thing happens? And I would say no. Bed rest really hasn't been shown to improve any outcomes. In fact, it can become quite dangerous, because as your blood stagnates, bad things can happen. You end up with blood clots, and that's the sort of thing that we would like to avoid. Oh, what else? Hello from Mississippi. Oh, that's a woo-boo there. Let's see. I know I saw some more questions. Okay, this comes from Celine. Selenio, for a 45-year-old, should we use donor eggs instead of trying with your own eggs? Well, the thing that you have to know is that at 45, the odds of being successful with IVF to get pregnant are very, very low. Are they impossible? No, I wouldn't say they're impossible, but it's definitely an uphill battle, you know? And so, what many people will choose to do is to do your own cycle with a donor egg backup. Now, there are many clinics that will not offer you IVF at the age of 45 because the success rate is so low. They don't want to mess up their numbers. They want to be able to show that they have these, extremely high pregnancy rates. And so they won't do it at CNY. We will give you a chance. I don't recommend that you do cycle after cycle after cycle because, again, the odds aren't so great. But many people will use a donor egg backup, and what that means is that you do your stimulation. We retrieve your eggs. We have your partner sperm. And when we are fertilizing your partner sperm, you've also purchased a cohort of donor eggs and they are fertilized at the same time. It ends up costing you a little less to do it that way because the donor eggs are already there with your eggs. And so it's not a separate transaction that has to take place in the laboratory. So donor egg backup is a great thing to do because one way or the other, at the end of that cycle, you are likely to have embryos that have a very high probability of being able to get you pregnant. So, and that's what we're after. Well, let's see what else we got going here. It's 27 minutes after the hour, and time is just flying away at Fertility with Fink and Friends. I am Fink, and you are Friends, and we are live via internet from Colorado Springs, and it is great to see everybody this afternoon. Let's take a look over again at the Facebook side here. Stacy can't wait to meet us in January, and I would say the same for you. Haley is here today. We had our consult in October, and we want to start our IVF process in July. Do I just need to message on the portal cycle day 1? So if your consult was back in July, you want to make sure that your lab tests are up to date, that you had the stuff done. Your consult was in October. So that's within a year. Usually the consultation that we'll do here is good for a year. The blood tests that you have in place are good for a year. We probably already put the medication orders in for you. So that's there. We just want you to have that in hand probably about 2 weeks before you're expecting to use them because we don't want you scrambling around at the beginning of that cycle, trying to get medications. But then, yes, you notify us through the portal on cycle day 1, and that's how the trigger gets pulled. I think it's very important to recognize this, and I want to say it again to anybody who hasn't had the experience. Once you've had your consultation with us at CNY, if you're not one of our local patients, our global team has a connection with you. Usually they have a phone call 1 to 2 weeks after the initial consultation where we will help you to figure out where you're going to do your monitoring for your IVF. We'll make sure that the medications are ordered. And once you've had that call, we're sitting around waiting to hear from you. You are the trigger for us to begin. So yes, absolutely. Let us know on cycle day 1. Usually you'll go and do a baseline, which is a set of blood tests and an ultrasound, typically by about cycle day 3. And usually we will start your stim by cycle day 5. That's usually the way that works. Let's see what else we got going here. Looks like Kalita, I might be transferring to Colorado because I live in Vancouver. We have a lot of folks from Vancouver, so it would be, which is a beautiful place to be, by the way, and a nice place to be from. So we will hopefully see you here in Colorado. But wherever you go in the CNY system, we will look forward to caring for you. Vanessa is here on Facebook. Is the placement of an embryo important? In the ultrasound pictures, it looks like it's not fully in the uterus. Is this possible? So Where we put the embryo at the time of an embryo transfer is very, very precise, and it is no accident. And so let me be 100% clear about this, because it is a common question, Vanessa, and I want you to understand. The catheter goes just inside the what we call the internal os, or just inside the uterine cavity. A second catheter goes through that one by about a millimeter or so, and then the embryo is placed. Now, where that embryo lands is entirely a product of your uterus. We think of the uterus as sort of being like a little hollow organ, and that you put an embryo in there, that it may end up being like, that it's just going to kind of shake around in there until it finds a place to land. But it's not like that at all, right? The uterus is what's called a potential space. And so it is sort of like this, right? It's the top layer is sitting on top of the bottom layer. And so the embryo will find a place that it feels comfortable, and it will start to hang out. Where you see that little white streak is not the place that the embryo will necessarily be implanting. Sometimes it may travel up to the fundus, to the top part of the uterus. It may look like it's on the top layer, but it's really on the bottom. So where it appears at the time of embryo transfer is not important at all. It should be inside the uterine cavity, but the entire transfer is done under ultrasound guidance, so that we can make sure that that embryo, that the catheter is just inside the uterine cavity, because that's how we know it's in the right place. The embryo gets placed inside, but it can float anywhere around and will continue to move. So it is, and I saw your picture, it's absolutely in the right place. Don't worry. Good deal. Heather's here. We tried doing a letrozole cycle, but ended up with a cyst. Okay, well, not sure what the situation was there, Heather, but letrozole is ovulation induction, right? So that's causing your ovary to prepare a follicle to be released. There are many times that people will get that follicle and they will have some kind of reason that they end up going to the emergency room. And in the emergency room, they get an ultrasound or they get a CAT scan or something, and they say, oh, you have a cyst, when what you really have is a follicle, because that's sort of what the radiologists call it. People who are non-gynecologists will call those cysts. And then forevermore, people will in their medical history say, oh, I had a cyst and it took me to the emergency room. Now, there are some cysts that are not normal, but a cyst in the ovary is something that each and every woman who ovulates will form every single month. So I want you to know that in many, and in fact, most cases, ovarian cysts are normal things. Again, not always, but doesn't mean that there's something wrong. Hi to Hot Devon. Nice name. Okay, Sarah Monera. I like that name too. Diagnosed with endometriosis and an unsuccessful IUI. Thinking of trying another round. What do you think? So when people talk to me about IUIs, there's absolutely nothing wrong with doing an intrauterine insemination or an IUI. They work about 9% of the time. So the success rate with an IUI is about 9% per cycle, which compared to home intercourse, a home intercourse cycle is probably about 1% per cycle effective, generally across the board. So to do an IUI is like 900% more successful. Wow, that seems pretty good. But in the grander scheme of things, an IUI is still not all that successful. 9% per cycle is not great when you compare that to something like IVF, where we can offer you up to a 60% probability per embryo, which is an order of magnitude higher success rate. So the fastest path to pregnancy, the most reliable path to pregnancy, is always going to be IVF. But if you get pregnant doing an IUI, Well, wow, you're a hero. It worked the way it worked the way it was supposed to. That's fantastic. So I don't have a problem with anyone who wants to do IUI, but my recommendation is that if it doesn't work after a few cycles, don't keep doing it. The evidence shows us that more than 5 cycles of an intrauterine insemination results in pregnancy rates that are going to be no higher than doing home intercourse. So I wouldn't want you to do that. And to be honest with you, even after 3 cycles of IUI, it gets really hard to keep doing it because every single month you're looking at the calendar, you're looking at the clock. Did I take my pill today? Am I supposed to be using estrogen? Am I supposed to be on progesterone? What the heck is happening? When do you have to give your sperm? And when is it going to go in me? And for crying out loud, then you get a period and you feel like, oh, what a failure. I got a period. So, there's not only a financial cost to it, but there's an emotional cost. There is emotional capital spent every time we try to do something in the fertility world. So if it's not working after a few cycles, you've probably already spent about as much as you're going to spend on a cycle of IVF that is going to give you an order of magnitude higher success rate. So that's why I say when someone tells me, well, we tried these IUIs, but they didn't work. Okay, I'm fine with that. That again doesn't mean anything is wrong, because sometimes they work, but honestly, most of the time they don't. It's better than home intercourse, but it's still not a great method overall. And that's my 2 cents worth on that. Let's see. Kel Dobbs says, if I were to have embryos left over, can we donate them to other families? I'd say absolutely. And what a wonderful and beautiful to do, because there are so many folks out there who are desperately desiring a pregnancy and are having trouble with their own embryos. Kel Dobbs, that is, you are from heaven for even asking that question. Yes, embryos can be donated to other needy families. And truly, what a wonderful, that is the equivalent of a heart transplant to someone who needs it, an organ transplant. Really a very beautiful thing for one family to do for another. Thank you, Kel, for asking that question. Let's see. M. Galaviz is asking, can you explain beyond the price the difference in stimming with Menopur versus low-dose HCG? Yes, absolutely. All right. So when we're doing IVF, right, there are a few different medications that we normally use. The first is an FSH medication, follicle stimulating hormone, and that is Gonal-F or Follistim. That's usually, in most people, that's the mainstay. Now, sometimes there are some oral adjunct medications that we may add to that, like letrozole or clomiphene. But FSH is the main drug, Gonal-F or Follistim. There is another hormone that we want to manipulate, which is LH or luteinizing hormone. HCG, LH, acts as luteinizing hormone, and it is much less expensive than its alternative, which is a drug known as Menopur. Menopur is the brand name for something called human menopausal gonadotropin. And what that means is that it's actually derived, or at least it was originally, I don't know if it still is, but it was originally derived from urine from menopausal nuns in Italy, believe it or not. So if you're menopausal, if you're in menopause, your estrogen levels are low. And when your estrogen levels are low, your brain says, we want more estrogen. So how does it do that? It secretes a hormone from the pituitary gland that's called FSH. FSH, follicle stimulating hormone, tells the ovary, produce an egg, make a follicle, because the cells in that follicle are where you get your estrogen, like we talked about before. So it's trying to make you make more estrogen. But if you're in the menopause, you don't have any eggs left. The eggs are gone. And so your FSH levels are very high, and they are ultimately secreted into the urine. So if you get a bunch of nuns who are menopausal and collect their urine and purify out the FSH, it's a great source of very good natural FSH. So HMG, human menopausal gonadotropin, or Menopur, is predominantly FSH, but also with some LH in it. Menopur may be associated in some circumstances with better egg quality. There are some protocols, particularly for folks with a diminished ovarian reserve, where we may use Menopur alone or change the ratio so that you're getting more Menopur than you are Gonal-F or Follistim. The cost of Menopur ends up to be about roughly about $85 for a vial, and one vial is 75 units, and that's usually the minimum dose that you would use daily. So a dose of Menopur may cost you $75 a day. If you're on 150 units of Menopur, it's going to cost you double that, because that's 2 vials. It's significantly more expensive than one vial of HCG may cost, what, $125, $130, but it's going to last you for the entire cycle. So we tend to start with low-dose HCG unless insurance will cover the Menopur, in which case then we'll say, let's use Menopur instead. And when that happens, we can use Menopur instead if insurance will cover it. But starting with low-dose HCG seems to give us very good results. There are times that we will then want to, let's say that the first cycle something happens, maybe we don't get as good an outcome as we might have hoped. And so then we may switch over to Menopur in another cycle. Menopur is not a part of one of the bundles, and it is more expensive. And so we don't want to kind of cut people off at the knees price wise on medications, when in many cases HCG LH will do just as well. So it just depends. If it doesn't do just as well, then we step it up to the next option, which would be Menopur. Hey, that is a really good question. So thanks for asking it. Arath says, what is the benefit of letrozole with a trigger for a modified FET versus just using a trigger? Worried about letrozole causing a thin lining. Well, so letrozole as a medication for ovulation induction, in theory, should not have an effect on your uterine lining. And so why would we even wonder if it would have an effect on the uterine lining? Good question, because if we use Clomid, clomiphene has a negative growth effect on the uterine lining, but letrozole does not. And in fact, as I mentioned a little earlier, the evidence shows that the effect on the uterine lining is actually very beneficial with a modified natural FET, that it's not only not thinning the lining in most cases, it's actually helping some chemical factor in that lining, which affects implantation. So again, another great question. On the Facebook side here, let's see, Jessica is saying, thank you for being so optimistic at our transfer. I'm really glad you were able to do our retrieval and transfer. Jessica, it is my pleasure. And it is just wonderful to be able to help people with their families. And it's a real honor to have had you here under my care. So thanks for being here. Tori says, do you have a recommendation for a frozen transfer? I have one day 5 4BB or 2 day 6 3cc. They are untested. What happens if the 4BB doesn't make the thaw? Will the other 2 be able to thaw without canceling the cycle? All right. So the first thing I want to mention there is you may have heard me say this before. I do not get all tied up in an embryo grading, because the embryo grading was really developed so that an embryologist can look under the microscope and describe a certain set of features and attach some value to them so that you can come up with some kind of grading nomenclature, 4BB, 3cc. But the thinking was, well, would that be able to help us determine which of the embryos are chromosomally normal. Because once you test an embryo and once you know that an embryo is euploid, that is chromosomally normal, the grade really doesn't matter anymore. Euploid trumps anything about grading. And anybody who has had PGT testing can tell you that you may be all over the map with what those embryos look like chromosomally. Your best graded embryo, your most beautiful embryo, the winner of the beauty contest, may have complex chromosomal abnormalities, whereas your poorest graded embryo may be the one that's completely normal. So I would not get hung up in that embryo grading. It is purely about how they look under the microscope, which does not correlate specifically with outcomes. All right, so that said, when we do select an embryo for transfer, they will usually pick the prettiest one. Why? Well, because, otherwise it's really pretty arbitrary, although that's not much different than being arbitrary. So I would tell you, please don't worry too much about that. Now, it is a thing that sometimes embryos do not survive the thaw. And if that's the case, well, gosh, why does that happen? When they go to freeze an embryo, the process they use is called vitrification. And in the olden days, it used to be a slow freeze where they would try to be very slow and methodical about it, because if there's even one little droplet of water inside that embryo, when it freezes, that can form an ice crystal, and that ice crystal can destroy the embryo. With vitrification, what they do is that they make a little nick in the membrane, and they really let the water kind of drain out. They suck out the water from the embryo, and it's frozen very quickly. They have learned now that that's the best way of doing embryo freezing. The success rate with embryo freezing and thawing is said to be about 97%. But unfortunately, it is a thing that 3% of the time, for one reason or another, an embryo does not survive the thaw. If you are down to your last embryo and you are here for an embryo transfer and that embryo doesn't survive the thaw, that is a very difficult conversation for us to have. And unfortunately, there's no way around it, because if the embryo disintegrates, then we really don't have any good options. Sometimes people will want to transfer more than one embryo, and one of those embryos does not survive, and so then we can simply thaw another one in order to be able to accommodate your wish for 2 embryos. 97%, though, is a pretty good survival rate. So I would at least feel confident with that. And that's sort of an industry standard. I think the industry standard is like about 93%, but in reality, most places are close to 97%. And that's what all the CNY facilities can tout. So good deal. What else we got going on here? Anything else to increase uterine lining besides estrogen? This comes from Ethereal. Well, what else can we do to increase a uterine lining? Sometimes we'll use vaginal Viagra. What does Viagra do? Viagra increases blood flow, and blood flow allows the hormone to get carried to that uterine lining, and it may result in a uterus thickening. What else can we do? A baby aspirin is a very good thing. Same reason for blood flow. But let's say that things aren't working as well as we had hoped with all of these things. There is an injectable estrogen that we'll use that's called estrogen, which fortunately is not expensive. It's another injection, so we try not to use it if we don't have to. That will often help to build a lining if that lining isn't responding. And we also really think about intrauterine PRP, platelet-rich plasma, which can be placed inside the uterine lining, which is full of your own tissue factors, healing factors, growth factors that can help that lining to grow. Let's see. What else we got going on here? What's the alternative for Omnitrope? So Omnitrope is human growth hormone. Growth hormone is what keeps us young. And so growth hormone potentially has the ability to help to repair some age-damaged DNA. Some people use growth hormone in just as a matter of, for anti-aging purposes, but we use it for folks with egg quality issue. I am told that there's a difficulty in getting Omnitrope now, that there's a shortage of Omnitrope, like there is a shortage of many medications. Maybe you have run across difficult time getting certain medications, just because there's, ever since COVID, there's big issues with manufacturing and lots of problems that companies are having. I am told that Omnitrope may be one of those things, and it's transient. Some days it's an issue, some days it's not. So there are some alternatives. There is a growth hormone alternative brand, the name of which is escaping me at the moment, but our prescription team can help you with that. They are very comparably priced. They essentially do the same thing. Their dilution is a little bit different, so the dosing is ever so slightly different. But if you are having trouble getting Omnitrope, then please do reach out to our prescription team. There is another type of growth hormone that we can use, now that I think about that, and I should actually have this conversation with Dr. Kiltz and the rest of our team. There is a drug that's called sermorelin, which is an injectable, and it is what is called the type of medicine that it's not giving you growth hormone, it is causing you to secrete more of your own growth hormone. And that is a wonderful thing too. It's also a little less expensive. It is not as well studied in the fertility world, but I don't consider that to be a deal breaker. Oh, well, let's see what we got here. And That's So Libra says at 24 years old and 2 ectopic pregnancies that ruptured with the loss of both tubes, but all other reproductive organs are healthy. What are success rates with IVF? Well, I would tell you that, with IVF, first of all, you're so cool because you're a Libra. And I just want to state that for the record, make sure that everybody knows. Very cool. With IVF, we don't need the tubes. And in fact, that's the reason that many people do IVF, so that because there is a tubal factor. So in the absence of fallopian tubes, Miss Libra, you are not going to be able to get pregnant. So IVF, the odds are extremely high for you at age 24. You are the kind of IVF patient that every clinic would want, because there is an extremely high probability that you will have all the pregnancies your heart desires. Why is that? Because if you're doing IVF at the age of 24, the DNA that's in those eggs is very stable. And so as a result, most of the eggs that you will make, 80 to 90%, are probably going to be normal, which are going to create normal embryos, which means when you put one back inside, when you transfer one, it will stick and you will be pregnant. So success rates are extremely high for you. Peps in her steps said, I had 6 failed IUIs and 1 failed FET. I'm starting to think there is a problem despite everything looking normal. Would you recommend more extensive testing? Well, so again, with the IUI, it's hard to say that there's something necessarily wrong, because they just don't work all that well. But you did an FET there. So, I would want to know for sure that your uterine cavity is normal, that there's no scar tissue from all those things going inside, that you don't have chronic endometritis, which is a chronic inflammatory process inside the uterine lining. I would want to know really that you don't have endometriosis as well, or some other problem in the fallopian tubes that may be causing issues there. So I do think that that's worth evaluating if you haven't already. Let's see what else we got going on here. We've got some other questions. Let's see if in the last 5 or 6 minutes we can get a few more here. Melissa Marie, if you have an early miscarriage, when are you able to start trying again? So basically the answer to that is let's say that you had a spontaneous pregnancy, you got pregnant on your own, and then you had an early pregnancy loss. We used to tell people that it needs to be we want you to wait for 3 months before you get pregnant. And there is zero evidence to back that up. That number 3 months comes from you're supposed to be on a vitamin with folic acid for 3 months prior to conceiving because that decreases the risk of certain types of spinal birth defects. But once you return to your normal cycle, you can try to get pregnant again there, Melissa, without any increased risk of another miscarriage. Somebody did ask me last week about there was said that there was some study that she saw that said it's 6 months for ideal outcomes. I have not seen such a study, and that is not yet any sort of evidence-based guideline for us. Shanti Dib is asking a good question. What do you think about PGT testing? Should we test our embryos? The best reason to test embryos with PGT would be one, if you've had recurrent pregnancy loss. So the most common reason that pregnancy loss or miscarriages happen is because of chromosomal issues with the pregnancy. So recurrent pregnancy loss, we recommend absolutely let's test those embryos and let's make sure that what we're putting in is believed to be normal. But if we have a large cohort of embryos, let's say you make 10 embryos, well, that may be a lot of embryos to have to transfer before you get to the ones that are normal. And so doing PGT testing lets us know, okay, embryos number 3, 4, 5, and 6 are the normal ones. And so they are the ones that have the highest probability of being able to get us pregnant. And so therefore, those are the ones that we're going to start with. That's what we're going to do when it comes time for embryo transfer. So it results in fewer unsuccessful transfers. If you are limited in the number of embryos, I do not suggest that you do PGT testing. Why is that? Because let's say that you got one embryo. So some people think, oh, well, because of my age, I'm 38 years old, so I have to do PGT testing. I'm an elderly pregnant person. So it's a horrible terminology, isn't it? So I have to test because we don't want to have a baby that has Down syndrome. Well, completely understood. However, in IVF terms, most chromosomally abnormal pregnancies will not implant. In most cases, you will not get a positive pregnancy test. And certainly that pregnancy is not likely to be ongoing. So the odds of having a chromosomally abnormal live birth are very low. If you have one embryo, you don't need the laboratory to tell you that that embryo is normal. If you put that embryo in, it's either going to stick because it's normal or it's not because it's not. So it's not really saving you anything, in my opinion. Now, there are some people who say, well, I don't even want to have to go through a transfer if that embryo is not normal. Okay, well, then that's a fine choice to make too. But even a chromosomally abnormal, or what we call an aneuploid embryo, still has about a 15% chance of giving you a normal baby. So PGT testing is just not perfect. It's not a perfect system. They're testing from the portion of the embryo that becomes the placenta, not from the portion that becomes the baby. So, again, it's not a perfect system, really best for narrowing down a larger group of embryos into the ones that have the greatest probability of getting you pregnant. All right, so hopefully that's helpful there. Lauren is asking, can the uterine lining be too thick at frozen embryo transfer? And no, not really. Now, if the lining is very, very thick, it always makes me want to know, have you had that lining evaluated? Could there be a polyp in there that's making it look thick? But if we know that the uterine lining is normal, let's say you had a hysteroscopy 2 months ago and there's nothing going on the inside, but you have a 16 millimeter lining, that's fine. There is no number that is said to be too thick. Good question there, by the way. Any recommendations on what to eat after an IUI? This comes from Alyssa. I'm keto carnivore now, and my IUI will be later this week. Well, certainly if you ask Dr. Kiltz, he will say keto and carnivore, and I think you're doing the right thing there. Carrie is here with us on Facebook. Follistim gave me some not fun side effects. What could I use instead? Breathing trouble, pelvic pain, and high blood pressure. Well, so that makes me wonder, Carrie, if that was a side effect from the medication or if that was an effect of being hyperstimulated. But in the event that it was concluded that there was an issue there for you with the medication, with Follistim, there is another one that's called Gonal F. And there is, of course, Menopur, and sometimes we will use Menopur alone without even any other FSH. So definitely some options there. Some folks may also choose to do IVF with just a little oral stimulation like some letrozole. Now, when we do that, we're not expecting to have a very grandiose response because the injectable medications will always rev up the ovaries better than an oral medication will. But let's say that you have a diminished ovarian reserve. Maybe you're a little older and you've done a cycle of IVF and you only with expensive medications and you got 2 or 3 follicles. Well, we might expect to get 2 or 3 follicles by just using letrozole. So maybe there's another way to do it without spending all that money on injectables. Just a thought. From Sally, my friend in Trinidad, did an FET and my midway estradiol came back at 2,800. Is this okay? Yeah, I don't worry too much, Sally, about congratulations. I think that's awesome. I don't worry too much about the estradiol level because really what's important there is that the lining got thick enough at the time of your progesterone start. So the level, honestly, we really shouldn't even truly be checking. But again, my 2 cents worth. Golly, it looks like we're going to be out of time today, but I sure have enjoyed being here with you, and I hope you got something out of it too. Thanks so much. As in every Tuesday, it's Fertility with Fink and Friends. I am Fink. You are friends, and my recommendation for you is to choose love. It's to choose kindness, and most of all, it's to choose hope. As this beautiful thing behind me says, or what may be backwards for you on Instagram there, infertility is not your novel. It's not the book of your life. It is merely a chapter. And we are here to help you rewrite that chapter. Hey, I'm not going to be here next week because taking the week off for the holidays. So wonderful. Happy holidays. Merry Christmas. Happy Hanukkah. Kwanzaa. Happy New Year to everybody. I will look forward to seeing you back here in 2 weeks. And until then, live from Colorado Springs, I'm Randy Fink. Good night.